Hello and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Pat Anderson, editor of MIMS Learning, and today we're going to be focusing on frailty. So I'm absolutely delighted to have with me, actually in person in the studio, Dr Alistair Robertson. So welcome, Alistair.
Good afternoon.
Alistair is a GP with an extended role in frailty for the Harrow Enhanced Frailty team in North West London. So first of all, my first question on the list is, what is frailty?
Well, that's a very good question, a very good place to start. And what I'm going to say back is, I'd like you to think about, first of all, what frailty isn't. Because before we try and think about what it is, it's best just to try and clarify all the things that frailty is not. And most importantly, frailty is not just about old age. There's lots of people who are older and not frail. Then the next thing people think about when they think of frailty is they think of disability. And again, you can be disabled and not be frail, or also have lots of medical conditions.
Yeah.
So it's not just old age, disability, lots of medical conditions. It's a little bit more complicated than that. The first thing you need to understand about frailty is a wholly separate condition, different from the normal aging process. And it's something that's becoming increasingly more important concept for GPs and healthcare professionals in general to know about, just largely because of the associated burden on the health service with it. But it's an essential concept just to understand the unpredictable health issues in some older people. And these can lead on to a host of potential complications. But it can be identified, measured, prevented, and even reversed sometimes. So if I could give you a couple of definitions as well, just starting with the American Geriatric Society, they talk about a state of increased vulnerability to stresses. These go on and largely to sort of age-related conditions, and they cause a physiological reserve to decline.
Right.
Now, that all sounds a little bit complicated. And then if I go into the British definition, we talk again about the distinctive health states. We talk about it being related to, but not directly caused by the aging process. They talk about multiple body systems gradually losing their inbuilt reserves, and that leading to an unpredictable deterioration. So there's a few things that they're alluding to there, but still, I can tell that you're thinking, I still don't really understand what frailty is. And this is very, very common.
Yeah.
Okay. So we then go into Kenneth Rockwood, who has one of the main models of frailty. Rockwood talks about deficit accumulation. So this is people collecting deficits. And as you collect these deficits, they become more susceptible to bad health outcomes. Now that's starting to get a little bit clearer, I sense. Yeah. Okay. Yeah. But then I hear you say, what's a deficit then? And a deficit is something that confers poor outcome and is common in older age.
Okay.
So if you're going grey and bald, that doesn't confer a bad outcome. Okay. But it is common in age. Whereas other things, like hypertension, that sort of thing, they certainly would be considered. So if you try and bring all of that together, we've got something that's a separate clinical condition. It's an accumulation of issues. They're more vulnerable, okay, to even little things. And there's this loss of their physical reserves to call upon. And it can lead on to this host of complications, okay? So minor things have major consequences, and then conversely, so small improvements and then can yield significant benefits.
Right, yeah. Okay.
Sometimes when I'm trying to explain about frailty, I use my burger analogy. What I'm alluding to is that frailty is a condition that is greater than the sum of its parts. So you take your burger, your bun, your lettuce, and your tomato, and all individually, they're nothing really. Yet you put the whole thing together and it's greater than the sum of its parts. So that's a bit like frailty, okay? And then the other thing I then go on and think about is say, look, if you take your frail patient, for them, life is like walking on a tightrope. Your eye, it's like walking on a pavement. You get a gust of wind either way. We can correct it without even thinking. But in frailty, a little nudge in either direction can be catastrophic.
That's a really good analogy. Yeah. I really like that one.
So they start wobbling, you need to grab them quickly before they fall. And that's, I think, sometimes people then kind of go, oh, I get it now. Okay. It's a challenging concept for people to sometimes understand. I think they probably know already, but they've never heard it called something before.
Yeah. Okay. So given that we have this condition of frailty, what's to be gained if it's addressed specifically?
Well, I think, ultimately this is about improving patient care, patients' experience and their journey through healthcare systems, or perhaps even keeping them away from healthcare systems as well. And frail people tend to really slip between the cracks, particularly in primary care, because the age we live in now, a very digital age, everything has been streamlined. And these sort of things don't fit well for frail patients. So, ultimately we're trying to save people money, we're trying to save time and effort and referrals. All of these sort of things cost money, they take up time and can set on a chain of events. So really it's first and foremost about the patient, but second of all about saving resources as well.
Yeah, okay. And if you don't mind me asking, how did you come to get your extended role in frailty? How did that come about?
Well, I rather fell into it.
Yeah.
I was on a WhatsApp group with a bunch of friends, and we were all complaining. And then one of my colleagues kind of went, well, I actually really enjoy my job. And I was like, well, what are you doing that the rest of us are not? And they said, well, actually, I'm doing this job. And we spoke, and it turned out that they were looking for more people. So I went along, and it went from there.
Brilliant. And I didn't include this in my list of pre-prepared questions, but what does your role as a GP with an extended role in frailty actually involve?
Okay, so a lot of driving is the answer. I'm a home visiting doctor. I go to my patients, and there is no substitute for a home visit. There really isn't. You're seeing your patients in the home, you get much better feel for what is going on. But really, week to week, I will, maybe on a typical few days, I will see a couple of new patients in their home. That involves looking at their electronic record quite a lot beforehand. What's the nature of the consultations been before I've gone to see them? Is it the families talking for them? Is it the patient? What are the issues going on? Blood results, clinics, a lot of trips to A&E, that sort of thing. So I prepare my notes. I go and see my patient. I'm usually with them for an hour and a half,
right?
Normally. I can't do it any faster than that. And I've been doing the job now for 4 years, and I can't do a proper comprehensive frailty assessment in less than an hour and a half. So, I go and speak to my patient, sit down, we have a very broad conversation. It's a very holistic assessment, and I'm very open about what you can and can't do. And I quite often make a really silly joke about not having a magic wand in my bag. I'm sorry, I can't make you, 30 years younger. But it's childish, because it sounds a bit silly and obvious, but you want to see, do they laugh? Do they react? Do they understand? That sort of thing. So we're getting it going, and it's setting out your process to say, look, I'm here to do a holistic assessment. I'm here to look all around. I then go on and say, you see a heart doctor, they just concentrate on your heart. Tests for the heart, medications for the heart, scans for the heart. I'm here to look at all of you. I'm here to look at your carers, your family, your house. And that's partly why it takes so long, because you look at everything, have a good look around, get them to show you your kitchen, all that sort of thing. So that's a comprehensive frailty assessment. That's the mainstay of my job. Then a few follow-up appointments, a lot of phone calls. I liaise a lot with local services, old age mental health teams, memory clinics, bladder and bowel, therapy services, trying to help my patient, get them seen by the right people. So then we have MDTs, meetings with local GPs as well. Quite often they have a little frailty team, so I have a little chat with them as well. So a lot of home visits, a lot of driving, a lot of admin, a lot of meetings. That's largely what my week looks like.
Yeah. Okay, interesting. And in amongst the GPs and their teams that you come across, how firmly established is the concept of frailty?
Well, look, I put it this way. I had no idea really what frailty was until I started doing this job. And it took me quite a long time to figure it out. The concept of frailty has only really been around for about 20 years or so. So it's fairly new in the grand scheme of things. I think the understanding is there, but again, they're not aware of what it's called. Oh, is that what it is? Is this what you call these patients who are very vulnerable to these sort of things? So I think they understand it. They've just never had it really formally kind of given a title before. But certainly, given what I've told you about, the time involved in all of this, primary care is not well placed to manage it because they're just so busy.
Yeah, because they just haven't got the time.
Yeah.
And when you talk to patients and their relatives, do you say the word frailty to them? Is that useful
It
concept
can be.
for them?
You call people and you say, I'm from the frailty team, and they go, well, I'm not frail.
Right.
And I'm like, and I might laugh and I go, well, that's wonderful. Then, we might not need to, stay very long. And yet other people you say, gosh, yes, doctor, that's exactly what they are. They're frail. So again, I think it's not something that's instantly understood by patients and families, but with an explanation, they quickly understand what you mean.
And so if I'm a GP, when should I have frailty on my radar?
Oh, it should always be on the radar. And it shouldn't just be the GPs. This is for everyone in the practice to look out for. Simple things, really, really simple things. Anyone, receptionists, nurses, pharmacists, social prescribers, anyone with any contact with patients or even just looking at their notes. So we talked a little bit earlier about Rockwood's model. There's another model out there by Fried. It's known as Fried's phenotype model. This has 5 characteristics which are very, very easy to spot.
Right.
So unintentional weight loss, self-reported tiredness, weakness measured by grip strength, reach out, squeeze my fingers. As simple as that.
Okay.
And walking speed and low physical activity. And out of all of those, it's considered the walking speed is probably the most sensitive one as well. So something as simple as watching a patient get up from their chair, walk across the waiting room towards a doctor's office, that alone could be a marker of frailty. And maybe just prompt somebody to say, we had a practice meeting the other day talking about frailty. This particular patient was very unsteady on their feet, getting up and across the waiting room. Things like that. That's something we could start doing today.
Okay. And if I wanted to be more proactive as a GP or a member of a team, are there tools that can help me to find the frail patients in my practice population? And
yes.
What are the limitations of these tools?
So, well, aside from those particular characteristics, you can look out for patients approaching end of life, nursing home residents, people who've been recently discharged.
Yeah.
Aside from that, you've also got your electronic frailty index.
Okay.
Which is based on Rockwood's model. There's 36 potential deficits. When they're coded into your electronic record, the score will just sift through, add all of these up together and create your score. Pretty straightforward, from mild, moderate to severe. So you could analyze your database of your patients, search through it and search by the electronic frailty index, or EFI as it's known, and just start largest number to lowest number, take the top 20 or so and go, right, well, what do we do with them? Mm-hmm. And straight away you might go, well, actually they're all right. But you could identify very quickly a small cohort of patients right away without doing anything more than that.
Okay. That sounds really
There is one limitation to that, of course, though. As long as it's all coded.
Yes.
If it's not coded, it won't show up.
Yeah. So somebody has to have logged those aspects during a previous consultation.
Yeah, which is fine when it's things like atrial fibrillation, CKD, stuff like that. But there are other things, other deficits that maybe don't get coded. Things like the signs and symptoms, like falls, cognitive impairment, but particularly things like social isolation, mobility issues, being housebound, vision problems. These are sometimes things that kind of get lost a little bit.
Okay. And what are the practical steps you can take once you've identified that someone is frail?
You can create a practice frailty team.
Mm-hmm.
Take a GP or two, maybe a practice nurse, admin, physician's assistant, pharmacist, anyone who's involved. Create a little database like we're talking about with the EFI score. Then when you have a few patients, just do the simple things to begin with first. And by the simple things, I mean when the patient comes in, make sure you confirm all of their details. Where do you live? How do you get into their house? They have a key safe. They have a neighbour with keys. Can they answer a phone? Mm-hmm. Do they have a mobile? Do they have any idea what a text message is? If not, stop sending them text messages, okay? So all of those sort of things. So just finding out, how do I get a hold of them? If the phone rings, do they make it on time?
Yeah.
Quite often not.
Yeah.
All of those sort of things. So then you can get a little bit deeper into frailty things, looking at things like polypharmacy, which can be a real problem in frailty, just largely because they collect medications as they get older. So that's certainly something to think about. Then you can get more, when you've got your little cohort of frail patients and you're getting more of an idea about how to do it, then get a better idea of the non-medical things you can do. As we've said, you can't fix everyone. You can't necessarily fix their coronary arteries or their CKD, but what can we do? We can make sure that they're living safely. Can we help by having pendant alarms, fall alarms, key safes? Can families be advised to do any sort of CCTV, door alarm, stuff like that? Do they need benefit? Do they need to be told that they probably shouldn't be driving? So lots of things that we probably think are obvious, but it takes a minute just to sit down and run through them all. Okay, so there's lots that can be done. Mm-hmm. It's just having the wherewithal and a starting point sometimes. And medicine as well. I mean, particularly polypharmacy, as we talked about a little bit earlier. This is something you could really make a big difference very, very quickly as well. So if you get your pharmacist on board and say, look, which one of these medications do they really need? Are they bedbound? Do they really need to be taking alendronate?
Right.
They've been on it for 150 years. Do you think maybe we should stop it? Right. That sort of thing, lots of medications with the alkylinergic burden. So lots of simple things that we can do. Can you get a Dosset box? Carers can give from Dossets. They can't give from packets. So, all these little things that can make a big, big difference. And as we said earlier, small differences can have really big improvements as well.
Well, that's a very positive thought. And obviously, all this takes time. So what's the implications for everyone's workload?
Yeah, it does take time, but ultimately you can save time. A little investment in time just to get your frailty team together. But it's not just the GP practice and primary care that you're saving time and money for, but it is your healthcare services as well.
Uh-huh. Yeah.
Do they really need to have a referral to cardiology, neurology, et cetera, et cetera, et cetera? Do they need this? Do they want this? Would they benefit from this? So we can save money, save time, and again, coming back to patient journey, are they really suitable for anything? So we're always the NHS will keep scanning you, scoping you, prodding you, and poking you for as long as you like, or as long as you keep waving at it. Mm-hmm. And just because we can do these things doesn't always mean we should. And in the frail populations, really, less is more. It's all too easy to fire off a fit test, and before you know it, some of you got letters going out for colonoscopies and all sorts. So this is all about stopping that chain of events that can happen, nipping it off early. So it's saving time, saving your colleagues' time, saving your local services money.
And is there any way that it comes back to the GP practice if you've created that benefit? Is there any way that you can get support for having done that?
I think this starts with the commissioners, depending on wherever you are and as they see fit. Yeah. But when you sit down and you explain how effective you are at maybe saving money, when you think about saving admissions, then you can really stack up the savings very, very quickly. Managing people in their home can be so much more beneficial for the patient, keeping them out of hospital. I mean, there's really, at the stage we're at now, you need to be really clear that if and when and why you're sending somebody to hospital. Because frail patients do not do well in hospital. They lose muscle mass. Their mobility may just tip over altogether. So you can put the financial case together to say, I've saved this many admissions. You can say, oh, I've saved palliative care this many referrals, so I'm saving them money, I'm saving admissions, I'm saving everybody money by doing all of this.
Yeah.
And I think that can be very powerful, because obviously we live in an era now where healthcare budgets are very tight. So that's how we can justify our existence if doing well by your patient isn't enough.
If you're a GP looking at a frail patient and thinking, well, they could really do with some help, but I don't want to, as you say, just send them to a cardiologist or whatever. Mm-hmm. Are there sort of such things as frailty specialists, and how do you refer to them?
Yeah, I mean, again, it depends on your area, but I'm slowly noticing more and more frailty teams existing out there.
Okay.
There may be different versions of them. Hospital teams are now, you're seeing more and more kind of frailty services there. They might be running next to the ESTEC, ambulatory care, those sort of places, or A&E might have their own frailty team who come around. Really like to see more of them brought out into the community. But again, it depends on your area. And if there isn't one, ask your commissioners to maybe think about one. And this will benefit all of the local practices, certainly. So yeah, it depends a little bit on where you are, really.
Okay. But it sounds like they're growing a little bit.
I think so.
Yeah.
The concept is really, I think people are really starting to understand now that this is where we're going.
Yeah.
With our aging population, we really need to be thinking about how we manage frail populations. So yeah. I definitely feel it's expanding.
Yeah. Okay, well, that leads on very nicely to our next question, which was really thinking about what's the direction of travel here and what do you hope will change? What do you see changing at the moment?
Well, certainly an expansion of frailty services. I strongly feel that keeping patients in their home is good for everyone. Mm-hmm. So whatever you want to call it, whether you're going to call it frailty teams, virtual wards, care at home, keeping the patient at home is much better for them. So this is the way I see things going. More of these types of services, but whatever you want to call them, though. So how we go about doing that, we can't expect GPs and primary care healthcare professionals to be going out and seeing their patients in the home due to the amount of time it takes. So having separate home visiting teams is so much more sensible.
Right.
However we go about that, it would be great to have a bit more engagement from commissioners around the country to spot the potential benefits of all of this. But again, it's the commissioning side of it's not so much my area of expertise. Managing these patients, it takes time, it takes patience. So it's like every other skill. It's an apprenticeship. You need to get out there and see it and learn it. So I would like to see a lot more community-based frailty services with good links with the local hospitals and the other services. Our team has a wonderful consultant geriatrician who's on speed dial for me.
Oh, brilliant.
That we can just talk about things and just say, look, what do you think about this? There are so few right and wrong answers, so few yes and no's in my line of work. Everything is grey areas. Admit, don't admit, stay at home, go to a care home. Do we do investigations or not? It's all about discussing it, making sure everybody's happy that you know why you're doing things. But these things, you can't have an individual just on their own trying to do all of that. You really need to be part of a bigger team that you can discuss all of this with, because it's so challenging and daunting to try and make those decisions on your own.
Yeah.
And you need to be able to speak with your colleagues and say, well, how would everybody else do this? What do you all think? At least we have these wonderful MDTs where we have lots of people on there and we'll discuss how they would approach things differently.
Yeah.
So it's good to talk, but it takes a bit of organisation. So whatever we do, lots more community services, lots more home visiting teams, lots more of trying to keep the frail out of hospital.
Yeah. Yeah. Okay, brilliant. Say I'm a hypothetical GP. I'm interested in frailty. I'd like to take the first steps. One thing that you've talked about is looking at the electronic frailty index, and you could perhaps find a small cohort of patients in your practice and start with them. Any other sort of first steps that you could take in terms of, you talked about communication, multidisciplinary teams, like to help with that side of things?
Yeah, so look, I think finding the patients, that's the easy step. There's lots of them out there. I think you pick up the phone and, if you get a list of 20 patients together, you pick up the phone and you can find out, because you might not, in the good old days of knowing all of your patients are long gone with the size of our list, even with named doctors. But actually having a named doctor or a single point of contact with your frail patients really is something that's helpful, right? Because they slip through the cracks. Finding your patients, whether it's by just looking at your collection of patients that you put together, or finding them anywhere, I think you just need to give it a try. Pick up the phone, talk to them, and just say, what can we do? How can we help? What do you need help with? It might seem a little daunting, but I think give it a go. Just sort of try and see, could I go round, or can I get somebody to go round and do a frailty assessment? Right. And the frailty assessment, we started going into it a little bit, but that's really how you find out what's going on with your patient. You do your frailty assessment. You pick up the phone, you say, I'd like to come round and see if I can help. It doesn't have to be any more complicated than that. You don't need to mention frail, you don't need to mention anything like that. But you could look at them, see, okay, they've got a high frailty score. Pick up the phone, go round and say, I'd just like to come round. And you have a nice open conversation about it. The other concept that we haven't quite touched upon yet is the power of you being there. Right, okay. The doctor is the medicine, that sort of concept. Holding space, just being there is very, very powerful. You've gone round, you seek your patient out, you're there, you're sitting there, you're listening to them. You say, I can't necessarily take this and that away, but I still want to help. And that can be extremely powerful for a patient. So pick up the phone, go and see one, have a go at a frailty assessment, which is essentially a bit of a chat. And the finer points of it you'll pick up. But that's my advice. Just try and carve off a little bit of time to do that. Go around, see them, have a go at a frailty assessments, look around their house, ask them what could help, ask them you've gone to A&E 11 times in the last 2 years. Is there any way we can help with this? What is it that's driving all of this? Is it something straightforward? Is it a piece of information? And sometimes help can just be answering some questions, saying, why is this happening? Why is that happening? Why, just providing advice, explaining things, unpicking things, showing that you're interested, and seeing those results are extremely satisfying. Yeah. So I think give it a go is what I'm trying to say. Okay, just great. Give it a go. Yeah. So you don't feel that people should be going out and doing a special training course first or anything? You think that it would kind of come from there? If you start with the process, then you kind of identify what else you might need to know. If I can do it, anyone can do it. Right. Take it from me. I'm not particularly bright, but I try and work hard to compensate for that. I did the DGM, which is the Diploma in Geriatric Medicine, which was wonderful. It helps you focus your learning. It's not essential, but yes, it helps, certainly. There's nothing like getting out there and seeing it. Yeah. That's for sure. Yeah. It is an apprenticeship, medicine. And frailty, I think, you do certainly start to get a feel for. Yeah. But yeah, get out, give it a go. Brilliant. I mean, I'm sure, most GPs will be regularly seeing older patients with complex care needs and complex medical conditions. I sometimes wonder, but both my parents are retired doctors, one was a retired GP. I sometimes wonder if what I'm doing is what GPs used to do back in the day, before text messages and patches and all the rest of things. Interesting. I just wonder whether this is what they used to do. And I'm sure it is, because like I said, I'm not doing anything groundbreaking, but perhaps it's that we're afforded a little bit more time to do it, maybe. But that initial time that you spend with them, it reaps so much dividends down the line. Yeah. In terms of trust and understanding through the patient and the family, that they then, when you have that conversation, saying, well, you remember we said this might happen, I think we're probably heading towards that time, it can really, really help.
Oh, well, thank you very much for talking through your role and the concept of frailty and what GPs can do in practical terms. I would suggest one thing GPs could do if they're interested is to read the clinical review that you wrote for us a little while ago about frailty. That might be a good starting point to just reinforce what people have heard today. And we'll try and keep the coverage of frailty up on MIMS Learning because it seems to be such an important area. Thank you so much for coming in.
My pleasure. Thank you very much for having me. I really enjoyed that.
Yeah, really appreciate it. And we look forward to seeing you again.
Brilliant.
At the next time. And don't forget, you can claim CPD credits for listening to this podcast. So be sure to go to mimslearning.co.uk to download your certificate and find links to useful resources and further reading. Thanks for listening. We've been the MIMS Learning editorial team, and this episode was produced by Till Owen. Don't miss next week's episode on dermatological presentations of systemic disease. We'll see you then.